Good evening, everybody. Welcome. My name is Rose Jansen. I'm with the Academy of Science St. Louis, and we're very pleased to be able to bring you science seminars in partnership with the St. Louis Zoo. Some of you are Academy members and friends, and for those of you who aren't, I'm going to take just a moment to tell you a little bit about who we are. We're an independent science organization. We've been around for a very long time, since 1856. We're supported entirely through community contributions, and we have been connecting science in the community since that time. And we do that today through a very broad range of free and low-cost public science programming for teens, adults, families, middle school students, and educators. That includes citizen science and inquiry-based learning opportunities, collaborative seminar series, and trips and tours that highlight science at venues throughout the metropolitan region. You can find more information on the Academy and our community-wide events and programs and public talks by visiting our website at academyofscience.stl.org. You may also visit us on Facebook or Twitter, or before you leave today, pick up some of our literature that is at our table outside the auditorium. If you're interested in helping to support the Academy's many science opportunities for students and adults throughout the metro region, there is also membership information at the table outside the auditorium, or I'd be more than happy to talk with you after tonight's talk. If you'd like to receive e-notification of upcoming Academy public lectures and events, there are some e-news sign-up sheets that will make their way around the audience tonight. And if you are a student who is here this evening and you need to verify attendance, we can do that for you after tonight's Q&A if you head out again to the table that's outside the auditorium. I do want to mention a couple upcoming events you might have an interest in attending. On Saturday, April 12, from 12:30 to 2 p.m., and in partnership with Circus Flora, you might want to join us at Bumbershoot Aerial Arts for Science of the Circus. You'll explore the exciting world of the circus, learn about the neuroscience of magic, and more at this family fun and interactive event previewing St. Louis's very own Circus Flora. This event is also free and open to the public. You don't need to register to attend, and discounted tickets to the circus will be available at this event. Green Resources Manager for the Missouri Botanical Gardens Earthways Center and producer and host of KDHX's Earthworms and KTRS's Growing Green St. Louis, Gene Ponzi, will be here in the Living World Auditorium on Wednesday, April 16 at 7:30 p.m. to talk about Sustainability 101, Grounding Green across the Gateway region, and that's as part of our Conservation Conversation series in partnership with the zoo. And then lastly, on Wednesday evening, May 14, Academy Fellow, neuroscientist, and science fiction writer Dr. Eric Luthart will be here to talk about his work and his recently published science fiction novel, Red Devil 4, which is a futuristic thriller about a neurosurgeon brought to assist police with a series of murders in St. Louis in 2053. Dr. Luthart is the director of Washington University's Center for Innovation in Neuroscience and Technology and the fifth most prolific inventor in the world with about 750 patents either granted or pending. There's a book signing following his talk, so you'll have an opportunity to have a copy signed by the author. You can find even more science opportunities, tours, talks, and events on our website or again on the event flyers and the Academy literature that's available for you to take with you before you leave tonight. And then with that said, I'd like to introduce tonight's speaker, Dr. John Morris. Dr. Morris is the Harvey A. and Dorismae Hacker Friedman Distinguished Professor of Neurology, Pathology, and Immunology at Washington University in St. Louis, where he is also director of the Center for Aging, the Memory and Aging Project, and the Charles F. and Joanne Knight Alzheimer's Disease Research Center. Dr. Morris is also an Academy of Science St. Louis Fellow and a recipient of the Academy's 2013 Outstanding St. Louis Scientist, Peter H. Raven Lifetime Achievement Award. He is the principal investigator for multiple research grants awarded by the National Institute on Aging to study various aspects of Alzheimer's disease, and is the author and co-author of over 400 peer-reviewed journal articles, 60 chapters, and reviews. The focus of his research and practice is Alzheimer's disease and other neurological disorders associated with aging, and his specific research interests include improving the diagnosis of early-stage Alzheimer's disease, clinical pathological correlations in dementing disorders, evaluating new drugs for the treatment of dementia, establishing phenotypes for inherited forms of Alzheimer's disease and other dementias, and identifying preclinical stages of Alzheimer's disease by biomarker and neuroimaging studies. We're honored to have him here with us this evening, and he is here tonight to talk about current trends and recent momentum in Alzheimer's disease research and clinical prevention trials. On behalf of the Academy of Science St. Louis and the St. Louis Zoo, won't you please join me in welcoming one of the world's foremost Alzheimer's disease researchers, Dr. John Morris.
Well, thank you very much, Rose, for that generous introduction. This is going to be a lecture focused on, as it says, new directions, so new ideas, new developments related to dementing illnesses, specifically Alzheimer's disease. Now, I plan to leave lots of time for questions, so if we want to talk about other aspects besides new directions, what is Alzheimer's, how it relates to dementia, and things of that nature, please to do that, but the talk is going to be focused on these newer concepts. As Rose mentioned, we're very fortunate at the Washington University Knight ADRC to have much of our funding from the National Institute on Aging, but you should know that I also receive funding from a foundation, from the Alzheimer's Association, and I have these consulting relationships with industry. Here are many of the extremely talented and dedicated investigators and staff of the Knight Alzheimer's Disease Research Center, but I point out that we wouldn't be able to do any of our studies without the dedication and commitment of now about 800 research volunteers, participants, and their families. So we're very grateful to their participation. I'm going to highlight one of the faculty. If you don't know his name now, I'm sure in years to come it will become very familiar. This is an associate professor of neurology at our Department of Neurology at Washington University. His name is Randy Bateman, and I'll come back at the end of the talk and describe a particularly exciting initiative that Randy is leading. So I said I was going to talk about new directions. These are going to be loosely characterized as a new way to think about Alzheimer's disease, a new concept, new ways to detect Alzheimer's disease using something called biological markers or biomarkers. And then last, talk about a new approach to treating the disease. And this new approach is focused on preventing it. So, new concept, biomarkers, prevention. First, the new concept. Most everyone, when you hear the term Alzheimer's disease, has a mental image of someone who is already affected by the illness. That is, they have the changes in their memory and thinking they have dementia. We've come to learn that Alzheimer's disease is almost a chronic disorder, that it is a brain disease that causes nerve cells to die, to degenerate and die, a neurodegenerative disease, but it begins many years before it produces that clinical situation that we think about when we hear the term, the demented person. What happens, as I mentioned, is that the connections between the brain cells and the brain cells themselves over many decades deteriorate and finally produce the dementia stage. So the new concept is this. We have two major stages of Alzheimer's disease. An asymptomatic stage without the dementia, without changes in memory and thinking, that lasts perhaps for 2 decades, and then the clinical stage that lasts perhaps a decade. So we call this asymptomatic stage preclinical Alzheimer's disease, because it's before the clinical symptoms, and also because, at least using our current diagnostic tools, we cannot reliably detect it. And then this symptomatic or clinical stage is what we mean by Alzheimer's disease dementia. Now, we diagnose Alzheimer's disease, we define it because once symptoms occur, that means that there's cognitive loss, cognitive decline that represents a deterioration from that individual's previously attained ability. So for that person, they gradually but inexorably lose their cognitive abilities, their mental abilities. It begins very gradually, but always progresses, and it is not, even in this very mild stage, a trivial complaint about memory, because in some degree it interferes with daily activities. And I'll give you some cases where we can ascertain this. So we have in that initial stage a terminology of the very onset of the symptoms. The clinical stage, we call it incipient Alzheimer's, prodromal. Popular term is mild cognitive impairment, but because it always gets worse, it progresses to frank dementia in all cases. Now, I want to come back about this idea of a intra-individual cognitive decline. What do I mean about that? How do we diagnose Alzheimer's disease? Well, I'm going to show you that our current methods really lack the precision that we might want, and in part it's because we measure cognitive ability, mental status ability, by giving an individual a series of tests. Now, what we want to know once the person has a test performance on a memory test, on an orientation test, on a visual test, on an attention test, whatever their score is, we'd like to know how they're ranked compared to their peers, people of the same general age, same educational background. We compare their performance to other people. And that works most of the time, but not all of the time, and here I'd like to illustrate when it lacks. So what I've shown here are the composite test scores on this axis of all of our healthy volunteers in our Alzheimer's Disease Research Center. And I've done it such that this 0 represents the average score of all of our healthy volunteers. Now, some people are really high performers. They're a standard deviation, even 2 standard deviations above the normal, and some are lower, a standard deviation or 2 standard deviations below the normal. But here are 2 individuals tested at the same time, a man, shown by this red square, and a woman by the yellow diamond. And at this time of testing, compared to other individuals in our study, this man is performing normally, right on the average of all of our healthy controls, and the woman is performing poorly. She's about a standard deviation and a half or so below the average of our healthy volunteers. This is comparing their scores to the large group of their similar participants in our study. So what happened over time? So the man declined. We test people every year, see them annually. Next year, he was down about a standard deviation. The year after that, way down. So he clearly is experiencing cognitive decline. But the woman stays the same. Poor compared to others, but same. But this isn't the whole story, because we had seen these individuals many times before. As a matter of fact, when the man came into the study, he was one of our top performers. He was a retired CEO, very highly educated, and he was scoring at the very top. And then he may have declined a little bit, but for about the next 5 years, he was pretty stable. But then he began here this marked decline. Really, the decline began here. The woman never was a good performer, but she never changed. So it turns out, I showed you the scores from this time. If we had seen this man then, we would have said, he's normal. He's compared to all of our healthy controls, he's normal. But that's comparing him to others. Comparing him to himself, he's clearly declined. Intra-individual cognitive decline. The woman, if we'd seen her one time, would have said, well, she's pretty poor, but look, she's never changed. She maybe doesn't like to take tests, but she's stable. So it's not comparing yourself with other people, it's how you're doing compared to your own past performance that's important. Here's the why this doesn't always work to help us in diagnosing Alzheimer's disease. Because we see people for the first time, we don't have the benefit of looking back and seeing how they were tested before. So what do we have to do to find out if they've changed? We have to find someone who knows them and ask questions. Are they doing as well as they did before? A colleague of mine, Jim Galvin, took our research assessment interview when we ask people who know the person well. Typically it's the spouse or an adult child or a friend or a colleague. And we looked at all the questions we asked these individuals, and we found 8 questions that gave us really in a very brief but still very predictive questionnaire, survey of how a person is doing compared to how they once did. So we're asking, any change caused by memory and thinking difficulties? And here are the questions. Is there more repetition? Unusual for this person. They're asking the same questions. Are they forgetful? Do they forget appointments? They have poor reasoning, poor problem solving, poor judgment. They don't make good decisions financially. They don't drive well. Problems handling their finances. Difficulty operating appliances. Are they disoriented? Can't remember the month or the year. Less interest and ability to carry out their usual activities. And overall, do you think this person has a problem? There's been a change for this person. So the bottom line is, a yes answer to 2 or more questions is indicative of dementia about 90%, 87% of the time. So if you have just silently tested yourself and come up with 2 or more, I'll be available after the... But I have to point out that it has to be a change for that person. If you ask my wife, does he have difficulty operating appliances, she'd say yes, but he's always been that way, not a change. So it's got to be a change from before. But these are the kinds of information we use to make a diagnosis of Alzheimer's disease, dementia. And it turns out we're not as good as you might think. This is just one study showing how accurate or maybe inaccurate the diagnosis is. It took individuals with a clinical diagnosis of Alzheimer's disease, dementia, made at Alzheimer's disease research centers, such as the one we have at Washington University, and then it looked at how many people, when they died, actually had Alzheimer's disease in the brain. And most of them did, but it turns out almost 17% didn't. These are by experts at Alzheimer's centers. This misdiagnosis rate is much higher when we move into settings that aren't expert settings, where busy physicians don't have the time to ask even much questions of the patient, much less of the spouse. So we're not as accurate as we would like to be. So we're moving into an era that I think will revolutionize how we diagnose Alzheimer's disease, dementia. We're looking at things called biological markers, biomarkers, and we now can see the brain changes of Alzheimer's disease in living people. Some of you may have heard the idea that, we won't really know if a person has Alzheimer's disease until they die and they come to autopsy and we examine the brain. Well, we can examine the brain now in life for those Alzheimer lesions. There are 2 ways we can do this. looking at the molecules that are abnormal in Alzheimer's disease. One is we could look at something called the cerebral spinal fluid, CSF. How do we obtain that? It's a spinal tap. Now, a couple things about spinal taps. First, why do we want to look at the cerebral spinal fluid? The cerebral spinal fluid is manufactured, generated in the brain. Matter of fact, it's essential for the brain to stay healthy. It surrounds the brain. It bathes the brain. It protects it against hard things such as our skull. And it also is a conduit for turnover of proteins and other metabolites. It not only bathes the brain, it travels down the spinal column to bathe and protect the spinal cord. So even though we withdraw spinal fluid from the low back, it's spinal fluid that has been in the brain. And if there are abnormalities in the brain, we can detect that by changes in the spinal fluid. You may have heard of infections of the brain, meningitis. How do we diagnose that? We do a spinal tap, we examine the spinal fluid for bacteria. So looking at the spinal fluid can tell us about protein abnormalities, and the two proteins that are critical for Alzheimer's disease are denoted here. It's called amyloid-beta, and a particular form of it, amyloid-beta 42. And what we find in Alzheimer's disease is the amount of amyloid-beta 42 is reduced. The other protein is tau protein, and its phosphorylated form, phospho-tau. And in Alzheimer's disease, they're elevated. So that's the signature of Alzheimer's disease. Low A-beta 42, elevated tau. For any of you who know about the disease, amyloid-beta 42 is the major constituent of the senile plaque. Tau is the major constituent of the neurofibrillary tangle. These are the two key brain lesions of Alzheimer's. So we have spinal fluid test of Alzheimer's disease. In addition, we now can image those senile plaques using special imaging tools, a positron emission tomography, a PET scanner, using different tracers that have very high affinity for those senile plaques, for the amyloid in those senile plaques. What we do is we infuse the tracer into a vein. It goes through the circulation, up through the brain. If there's no amyloid senile plaque there, it washes out and the PET scan is negative. If there are plaques there, the tracer binds to that plaque and it gives off a radio signal that the PET scanner can detect. These lesions, these amyloid deposits in the plaque, the tangles and the tau, are too small to be seen by any imaging device, so that's why we have to make these tracers that have a special signal that the PET scan can detect. So we have ways now to look at the brain lesions of Alzheimer's disease. We can look at the consequences of the brain lesions. What did I say about Alzheimer's disease? The major problem is brain cells degenerate and die. As they degenerate, they don't have proper metabolism. We can pick that up with another type of PET scan. As they die, they reduce the brain's volume and the way the brains are connected. I'm going to come back and talk about this at the very end. So I think as I said, revolutionized the diagnosis. We're at the beginning of this, the dawn, and most people are most enamored with imaging. Imaging is very powerful because we can see a picture of what's going on. And the Food and Drug Administration has been approving different amyloid tracers for PET scan. The first that was approved is florbetapir, but now we have two others that just been approved, one just last month, and others in development. So it's coming. Here's one of those amyloid tracers called florbetapir. And this is the brain tissue of a person who in life had a florbetapir scan looking for plaques. This person didn't have any plaques. The florbetapir scan, the tracer got into the brain, went all through the circulation, had no plaques to bind to and got washed out. So the PET scan shows a nice, cool blue color. There's nothing there. This little yellow in between is not the areas where brain plaques occur. It's the white matter, and so it's nonspecific binding. Here's another person who died after a Florbato-Peer scan. They have a moderate amount of plaques, and now we look in the brain, and it's not all blue and cool, but now we see some yellow, and it's not just in the white matter, but throughout. Here's a person who has lots of plaques, and we see not only yellow, we're even seeing hot red here. So the amount of Florbato-Peer positivity correlates with the amount of amyloid plaques. We don't have to wait for the autopsy now to recognize Alzheimer's disease brain lesions. We're not quite ready for the biomarkers. They're coming. We should be ready, but we're not. First, we don't know what I said, Florbato-Peer positive. What does that mean? When is something positive and when is it negative? We have to figure out those cutoffs. We haven't done that yet. Not everyone does these biomarker tests the same way. So a value in St. Louis may not be the same value in Kansas City. What does that mean? They're not standardized. They have been tested mostly in research settings. What about the real world, the clinics where patients come? Not everyone is going to have a PET scanner or be able to do a spinal tap. So there's going to be a variety of variable access to these tests. I'm going to talk a little bit about reimbursement. Right now, it's a mixed bag, and these are costly tests. I'll show you. And then the question is, what do we do about people who think they're at risk for Alzheimer's? Maybe they had an affected parent, and they say, well, yeah, I'd like a PET scan. What are we going to do with the results if somebody is positive and yet still normal? These are things we'll have to answer, but we have not yet. So I thought I'd illustrate a couple of these points from some cases that I've seen recently in my clinic. And just to give you some practicalities, one company called Athena Diagnostics has patented the spinal fluid test, the assays for the amyloid-beta and the tau protein, and they're charging somewhere in the range of $1,500 to $1,800 to do this test. Medicare will reimburse this. Many, but not all, private insurers will reimburse it, but some only 80%, and we've had the unpleasant experience of having a patient go through the spinal tap. We obtain the spinal fluid, we send it to the laboratory, and the laboratory says, well, your insurance company is only going to pay us part of it, and we're not going to process your CSF, we're not going to do the test until you, the patient, sends us the rest of the money. The amyloid scan is commercialized. Eli Lilly, the drug company, has now a wholly owned subsidiary, Avid, that developed this PET scan. And they, because we're an Alzheimer's center, give us a voucher that says that, well, you can do this PET scan for $1,400, but it's out of pocket, because Medicare and insurance companies have not approved reimbursement of this. If you don't have that voucher, and most physicians do not, the out-of-pocket cost goes up to $3,400. So this is quite expensive. Okay, so I saw recently a man who said he was a retired pilot. He worked with the military. He came from outstate Missouri. He had a college graduate, and he came along with his wife and their 30-year-old son. So both the wife and the son said that he's had the gradual onset of changes in his memory, beginning for maybe 6 years. And as examples, early on, he would uncharacteristically misplace items, and he couldn't understand what they said complex instructions. Now, this is where complex instructions gets interesting, because it began at age 56, but by age 59, he decided, thankfully on his own, to retire, because as he went through the flight checklist, he would later discover he had missed important items, And here's this complex instructions. This is air traffic control. Couldn't understand it. So fortunately, he retired as a pilot. Now, does he have a family history of Alzheimer's? Well, his mother died at age 65. She was not impaired. We don't, of course, know what would have happened to her had she lived longer. The father developed dementia, but he was quite old. And usually we say there's not much genetic risk to offspring if the parent developed Alzheimer's dementia after the age of 80. All right, so he had good health in general, at least stable health. He had sleep apnea, obstructive sleep apnea, high cholesterol. He was anxious. He had had a head injury with loss of consciousness, but he was quite young, and he didn't have any problems after that. Now, I thought he was depressed, and I thought his depressive features began at age 54, maybe a couple years before the memory problem, when he returned from his deployment to Iraq. Now, he said he was not exposed to any head injury, no blast, he wasn't in combat, and he denied post-traumatic stress disorder, but he was withdrawn, sad. He was really sad because of his memory problem, but he also said, I don't have these features, I'm not disinhibited, I can interact with people, I'm not thinking of suicide. But his problems were causing marital strain. He was taking a number of medicines. These are antidepressants, but all of these citalopram, buspirone, clonazepam, and lamotrigine can cause cognitive difficulty. So I was worried about how many and what types of medicines he was taking. So I looked back to his medical records. He'd been seen by another neurologist a couple years before, who also said he's got memory complaints. He took a test, a common test of memory and thinking ability called the Mini Mental State Examination, and got a score of 25. Top score is 30, so maybe a little low. A depression scale score was mildly positive for depression. And he took an image of his brain, an MRI. I don't know why he took it, but it was unremarkable. It had a good-looking brain. And he did have, I found his old records for his obstructive sleep apnea. He did have periods at night when he wouldn't breathe for 40 seconds or longer. So that was confirmed. He saw that other neurologist a year later. He got full psychologic testing, and he clearly had deficits in learning and memory and decision-making, but his mini mental state score improved a couple points. He went up a year later, 27. Got another brain MRI, and it was unremarkable, and there was no change from the brain MRI he had 2 years before, no loss of volume, no other abnormalities on examination. So the neurologist thought this was a problem. He certainly had deficits on neuropsychologic testing, but he wasn't getting worse, at least as measured by this mini mental state test. And we know in Alzheimer's disease, people always get worse. And it wasn't causing brain shrinkage. Plus, he had all these other factors that maybe figured in rather than Alzheimer's disease. So when he came to see me at age 62, the wife and son said he was very repetitious. He'd ask the same question over and over, even after they'd answered it. He'd forget conversations. He'd go shopping, put the bags of grocery in the trunk and forget them, leading to spoiled food. Friends would come to visit. He'd forget that they ever were there. He had taken care of the household finances, but now was forgetting to pay bills, or he paid some twice, forgetting that he had paid the first time around. He was very handy, but couldn't put in a ceiling fan. This is important. I could never put in a ceiling fan. So, but not a change. But for him, it was a change. He was having difficulty with appliances. However, he's still driving and no apparent problem and doing all the basic activities without difficulty. So he had a normal examination. He had no language difficulty. He had trouble remembering the day of the week. He was wrong for that. He was able to draw a clock and use the hands to indicate 8:20, and he could calculate the number of quarters in $6.75. But he came from outstate Missouri, so he and his wife and son had come to St. Louis the night before, stayed at a hotel, went out to a restaurant. He couldn't remember the name of that restaurant, nor what he ordered. And he'd forgotten, the son told me, that his son and wife had visited his home a month ago. He forgot that visit entirely. So on our brief testing, here's how he did. Here's the patient score, and here's our norm scores. Now here again, we're comparing him to other people in our project, which isn't the optimal way, but this is the first time of testing. So this is called word list recall. A normal score would be 7. He got 0, poor. Another memory test. Normal score is 13. He only scored 2. Here's a language test. Normal score is 18. He did well, 21. These two tests are how well the brain uses information. A normal score on this would be 105. And this is the only one where the lower the score, the better. He didn't have a lower score, he was higher. Now we're back to the higher score, the better. He should score 45, he got 30. But now here's his mini mental state test, about 23. So certainly has memory problems, and I would say processing problems as well. So I was like the first neurologist. I thought this man looked like Alzheimer's disease dementia. Gradual onset, getting worse, interfering with his normal activities. He had to retire because of the problems. He has problems shopping, he's mispaying bills, he can't operate appliances. But he's very young. Happened about age 56, or the onset, and he had no family history of young-onset Alzheimer's. So that's unusual. At least the first neurologist thought it wasn't progressing early on, although when I tested him, it was 23 on this mini mental state. No apparent brain shrinkage, and maybe all of his problems are not due to Alzheimer's. Maybe it could be depression or obstructive sleep apnea, all of those medications. So we decided then to do some biomarker testing. I've already told you about the FDA approving these amyloid tracers, but because it would be expensive, we decided to go with the the cerebral spinal fluid assay with that Athena Diagnostics. And there's another advantage of the spinal fluid assay. Not only do most of the time can it get reimbursed fully, but there's no exposure to radiation as with the PET scan. So he had the spinal tap for the spinal fluid. We sent it off, and this is the amyloid level here, and this is the tau level here. Remember, in Alzheimer's disease, the signature is low amyloid, and he was quite low, and elevated tau, and this would be, up to this line would be normal. He's higher than that, so he had a diagnosis consistent with Alzheimer's disease by this test. Now, I think what this did is two things. One, it tells us what he has is Alzheimer's disease. It helps support that diagnosis. And two, it prevents, if you will, a long consideration and other laboratory testing for the role of the other considerations that we were thinking about. So he has something. No one wants to have a diagnosis of Alzheimer's, but now he knows what's causing it. He can start to plan his life to deal with that, and we don't have to chase other non-Alzheimer causes to see if they're contributing as well. So we talked to him, and we said the test supports the diagnosis of Alzheimer's disease, and he has continued to slowly decline over time. So here's another person, even younger, a 45-year-old man who was highly educated, and he had actually not memory and thinking difficulties, but he had some problems with his right side, arm and leg, getting weak, then affected his walking. Because of this, part of his job had been operating equipment, but he no longer could do this. And his physicians thought maybe it's because it was so localized to the right side, maybe he had a stroke on the left side of the brain, or maybe he had multiple sclerosis. Matter of fact, they treated him with a multiple sclerosis drug for spasticity, back with him. So his prior history, he'd had a head injury, and he was treated with anti-epileptic drugs, but then stopped them and hasn't had any further seizures. He had an interesting family history. His grandmother on the mother's side was said to have Parkinson's disease and later developed dementia, and his mother, her daughter, was diagnosed with multiple sclerosis. And that's maybe why the physicians thought he had multiple sclerosis. So even though he has this right-sided weakness, he's working, driving, shopping, mowing the lawn, renovating the house. He's doing quite a lot. But she says there are some other things. He might forget to pay the bills, and he gets penalized. Even going to familiar places, he needs directions. And when he shops, he may forget items even with a list. So I examine him, and in fact, that's what he has. He's got right-sided weakness, worse in the leg than the arm, lower extremity, worse than the upper extremity. And he's got some other abnormalities on that side. And he gets this mini mental state examination. It's 26. That's, that's not 30, but not terrible. And he gets a diagnosis not from me, but of other people of mild cognitive impairment, not knowing what this really is. So having the presentation of motor difficulty with dementia is unusual, and there's a whole list of possibilities, including stroke. But we have to remember one of the possibilities is an unusual presentation of Alzheimer's disease. Does he have Alzheimer's disease? Does he have multiple sclerosis? Does he have all these other disorders? We looked at his brain MRI, and there's no indication of stroke. So that's number one, does not have stroke. And we do amyloid PET scan. We do it with not the Fluor-beta peer tracer, but another tracer. But you can see no matter what level of the brain we're looking, it's entirely positive, lots of yellow and lots of red. He has Alzheimer's disease at a very early age. When it happens below age 50, we always have to look at the family because it could be a rare inherited form of the disease, and that's exactly what he has. He has a gene mutation that's positive, and here's his family history. Here's that mother who had a diagnosis of multiple sclerosis. Almost certainly she had this early onset Alzheimer's. Here's the grandmother who had a diagnosis of Parkinson's. That certainly was wrong. He has a form of inherited Alzheimer's disease that causes both motor difficulty and this dementia, Alzheimer's dementia. So, by the way, this form of Alzheimer's disease, just for characterization, each offspring of an affected parent has a 50-50 chance of inheriting that gene mutation. So in some generations, each offspring may inherit it, 100%. In other, it's possible that neither did in this generation. And if they did not inherit it, then it's finished in that family because no one had the gene to pass on to anyone else. But most of the time, you have a 50-50 chance. Most of the time, it's 50% of the offspring in a generation that get the illness. So we'll just take a look here at what we think about Alzheimer's disease, memory problems, difficulty, brain shrinkage, we get these biomarker changes. In this inherited form, autosomal dominant Alzheimer's disease, we get the same kinds of things with two additional abnormalities. One, this motor problem, which this man presented with, and the distribution of the PET amyloid tracer is slightly different as well. But otherwise, it's a very similar disorder. But this is very rare. About 1% of all people with Alzheimer's disease have this form of dementia, so it's quite rare. All right, so let's turn to treating Alzheimer's disease. I haven't discussed that. As we reached the new millennium, we were very excited about new drugs that might really attack targets, the molecular abnormalities, and we started these in 2001. We've tested all of these compounds since then, and they've all failed. None of them have been beneficial. They've all been developed based upon sound scientific principles. They attack amyloid, many of them, amyloid, but not all. Some attack other targets, inflammation, insulin, so forth. They've all failed. Now, why is that? Well, here's the way I think about it. So the clinical stage of Alzheimer's, remember I said it lasts about 10 years. It begins very mildly and it gets worse and always ends in death. It's invariably fatal. If we study people who die of a heart attack or an accident at this very earliest stage of the disease, we find already in certain brain regions, 50% of the brain cells are gone. By the time we can make the diagnosis of the symptomatic phase of the disease, in some areas of the brain, there's irreversible, substantial damage. So we're treating a badly damaged brain. All of those failed trials were in people with symptomatic Alzheimer's disease. They had to be diagnosed to be eligible for the trial. The other thing is, in this symptomatic phase, it's no longer just one abnormality, amyloid abnormality, tau abnormality. There are many things that are going on. And all of those failed treatments were attacking just one mechanism. So if we're going to find effective therapies for people who have symptomatic Alzheimer's, and by gosh, I hope we do, we're going to have to start thinking of combination therapy attacking different mechanisms. But we're in the biomarker era. So now we can identify this preclinical Alzheimer's disease, which lasts for 20 years or more, and we can chart the course of this preclinical phase using those very same biomarkers that we're beginning to use in the clinic to diagnose the disease. And our theory is this, that it takes 20 years for these biomarker changes, the brain changes of Alzheimer's, to finally reach a level where the integrity of brain cells is overcome and they start to degenerate and die. This they can tolerate because as long as the brain cells are intact, no symptoms, but once brain cells start to die, get injured and die, it's inevitable that they'll become symptomatic. What happens if we intervene here? We have lots of anti-amyloid drugs, and we know in animal models they're pretty effective. Maybe we waited too long to give them. Maybe we need to give them earlier. All right, I showed you this scan before, but just to show you in healthy older people, cognitively normal, given an amyloid tracer and detected with a PET scan, the outside of the brain is where the plaques are. In this cognitively normal person, there were no plaques outside of the brain, stains blue. Here in the Alzheimer person, lots of red and yellow amyloid plaques everywhere. Look at this person. Here's another cognitively normal person. Their PET scan is exactly the same as the Alzheimer person. So I would submit, I don't know for certain, but I would submit that this person has preclinical Alzheimer's, and if they live long enough, they will become symptomatic. They will develop it if they live. Of course, I chose this representation because that's what happened. 3 years later, this person was diagnosed with Alzheimer's dementia. So what I'm saying is we're now at a stage where we can identify people at very high risk of becoming demented. And it's quite frequent in the population. These are all healthy people, cognitively normal, depending on how old they are. This is on their PET scans for amyloid scans. We can start to see the changes in people in their 50s, but by age 75, it's like 25 to 30% of cognitively normal people have what I would say is preclinical Alzheimer's disease. A third. So I want you to look at the person seated on your left and the person seated on your right, and if they don't have it, it's you. No. So 30% of cognitively normal people are biomarker positive, an indication of preclinical Alzheimer's. But here's what we know. We know that as a group, these individuals are at high risk of developing symptomatic Alzheimer's. What we don't know is whether everyone will develop it. We simply don't know. We haven't followed these people long enough to know that. Also, if they are going to develop it, we don't know when. So if I'm 66, say I got a PET scan today and it was positive, does that mean next year I'm going to become symptomatic, or at 96. I don't know. And so we can't tell people what the predictive, on an individual basis, what the predictive value is. So that brings us back to those mutations, because everybody who has a mutation is going to develop symptomatic Alzheimer's, 100%. 100%. So we can look at people who right now are asymptomatic, but they carry the mutation. We know they're destined to develop Alzheimer's, and we know about the age because it'll be about the age their parent got it. So we have this large study. It's an international study, dominantly inherited Alzheimer network. There are only some 500 families that have been identified across the world who carry these mutations. So we have sites in Australia, we have sites in Europe, and we have sites in the United States banding together to study these families to find out when the biomarker changes occur and which are the first ones. So we wanted to set out and get 400 individuals. Remember, 50-50 in a generation, so we expect that we'd get 200 who have mutation carriers, but another 200 would be non-carriers. They're siblings who didn't inherit the gene. And I won't go over the structure, but Washington University, the Knight Alzheimer's Disease Center, is the main coordinating center for all of this, and we have all these sites across the world. And I'll just show you about this initial outlook for what happens in this group of participants, a very, very dedicated group of participants. So we enrolled about a little more than a quarter of people who already are affected. Let's take a look at the mutation carriers, 88 of them, and they are about 46 years of age. Look at when their parents developed Alzheimer's disease, about 45 years of age. So it comes on at about the same age as the parents. Now, an interesting thing is look at 10 people who we think have symptomatic Alzheimer's disease, but they don't have the mutation. They're a little bit younger, 41 years, and the parents got it about 46. My idea is, or my ideas are, they don't have symptomatic Alzheimer's disease. They're worried as they get to the age where they approach when their parent became symptomatic, they start reporting symptoms, but in fact it's not true. Does that make sense? If you had a parent who was affected at a young age, and you grew up as a teenager watching your parent, and you knew the family had this gene and that you were at risk, believe me, as you get to be age 41, you're going to be very, very concerned. So here are the asymptomatic individuals, and it's not quite 50-50, but pretty close between the mutation carriers and the non-carriers. They're younger, but again, parental age of onset around 46 to 47 years of age. These people, because they know about the family history, are highly motivated, and they complete all of our procedures at a very high rate, including lumbar puncture, the spinal tap, not only at the first assessment, but also at the second assessment, because they know the value of trying to find out the cause of this illness. All right, I mentioned at the beginning, Randy Bateman, my colleague, he developed from all of these different entities a trial unit to try to bring to DIAN this dominantly inherited Alzheimer network treatment trials. And here are the first drugs that we're testing in asymptomatic mutation carriers. Now, these are anti-amyloid drugs. They're antibodies against the amyloid compound, and the hope is that we'll give them to individuals and we'll reduce the amount of amyloid in those plaques over a period of time. So here's the idea. We're going to enroll 210 individuals. They'll be up to 15 years younger and up to 10 years older than their parental age at onset. They'll be given either drug A or drug B, the mutation carriers, but we're also going to enroll non-carriers. Now, why are we going to enroll non-carriers? They're not going to get symptomatic Alzheimer's disease. Why would we expose them possibly to drugs that could have harm? The reason is, to join DIAN, you do not have to know whether you are a mutation carrier. And 90% of the DIAN participants do not want to know. So if we say, congratulations, you're eligible to enroll in our trial because it's limited to people with mutations, we've told them. So we have to enroll some non-carriers to keep the blind, if you will, but be sure that they all get placebo. Does that make sense? So this is the first ever treatment trial for this form of Alzheimer's disease, and it's the first ever prevention trial with anti-amyloid drugs. We put the first person into the drug phase a year ago, March. They came back last month for their follow-up visit. We've got people at Washington University as initial site, but we've just launched the sites at the trial at North American sites. And Randy Bateman on Monday with our DIAN team was helping the international group, Australia, Spain, France, Italy, United Kingdom. And he had to really sacrifice to do this investigators meeting to get them launched. He had to go to Monte Carlo and Monaco to have this investigators meeting. Anyone who is interested in the DIAN study, there's a website for it. And we're not the only one, we're the first, but other prevention trials are starting in the United States and internationally. So let me come back and tell you the points as I see it, because we all want to get truly effective therapies for Alzheimer's. We don't have them now, but we want to get them. Once symptoms occur, even in the earliest stages, it may be too late because the brain is already damaged. It may benefit from combination therapies, but we haven't tried that yet. Alzheimer biomarkers are going to change the way we approach this illness. We can use it in the clinic, but we also can identify preclinical Alzheimer's disease. I think amyloid therapies now have begun in asymptomatic persons at great risk of developing Alzheimer's. We'll find that we have much work left to be done, just how far away from when we expect the age of the person to become demented do we have to start these therapies? How long do we have to give them? What are we looking for to know that we've delayed or even prevented the onset of Alzheimer's disease? But for any of you who have a family member who has been touched by the illness, you all will know that if we can prevent this illness, we will do a great service not only for our families, but for mankind. Thanks very much for your attention. So I am happy to entertain questions. Sir?
Yes, you were talking maybe about these cases like this that refer to the United States. Is this a worldwide issue? I mean, the life expectancies are increasing all around the world in developed countries. Are other countries having the same problem in terms of the percentage of people getting Alzheimer's?
Yeah, so to sort of reframe the question, is Alzheimer's disease, the frequency of it, the same worldwide? The answer is yes. Countries that are more developed have more of an aging population and hence have more Alzheimer's disease. But countries that are less developed, India, China, others, have fewer people living to age 65 and beyond, but they have so many people, they have basically the same frequency of Alzheimer's as well. So there's no real national escaping from Alzheimer's disease. Yes, ma'am.
Is there any particular race or nationality that has been found to carry the genetic form, and what is the makeup of the study trial group?
So very difficult. You gave me two questions there. You'll have to help me remember the second one. So basically, Alzheimer's disease occurs in all racial and ethnic groups. That doesn't mean it occurs to the same degree. There is evidence that let me start, you both are very good, and I failed to appreciate how astute you were. Sir, you talked about the frequency of Alzheimer's disease, and I talked about age 65. What I didn't say is the greatest risk factor of all for Alzheimer's disease is living long. The older we are, the more likely we're to get it. That's why I was talking about developed countries and the percentage of people who live long. Age is number one. Second is genetics, family history. Now, I was presenting a very rare form of genetics, people who inherit a mutation. Most of us know that Alzheimer's disease can run in families, but it's not because there's a mutation. It's because our families have their own sort of broad genetic profile that we have. For example, my parents are of Northern European ancestry. That means we're pale-skinned, and I particularly pale-skinned. Before I had children, I had red hair. Which means that genetic profile, hypopigmentation, that's genetically determined, meant that I'm very susceptible to getting sunburned. And I got sunburned quite a lot when I was a kid. Now, did my genetic profile cause me to get sunburned? I had to go out in the sun, right? So we can inherit genetic susceptibility factors that don't cause the disease, but put us at risk for the disease. And those susceptibility factors can vary by racial and ethnic groups. As a matter of fact, some preliminary evidence suggests that African Americans and Hispanics are at higher risk of developing Alzheimer's disease than Caucasians and Asians. Okay? So there are some differences in the risk factors. All racial and ethnic groups are susceptible to it. Your second question was the composition of the DIAN prevention trial, and these are people only who come from families in which there's a known mutation for the disease. That's the rarest form of Alzheimer's disease.
I guess the reason why I was curious is because I'm assuming we're trying to maybe be able to apply those therapies to people without it. So that's why I was wondering what the makeup of that would be like.
So, a great question. When I talked about the man who had the right-sided weakness and turned out to have a form of this mutation form of Alzheimer's disease, I did a comparison of the features of this inherited Alzheimer's disease with the much more common late-onset Alzheimer's disease, and I pointed out that in many aspects it's the same presentation, same features, maybe some differences like the motor abnormalities, but the bottom line persists. We don't know if drugs work in this form of Alzheimer's disease, whether they'll translate to late onset. We don't know that. There's a precedent that we hope will work. First, we hope our drugs work in this form, and then, of course, in late onset. Some of you may be aware that there's a class of drug called the statins that lower cholesterol. They were first developed and tested in a genetic form of hyperlipidemia, people who inherited a gene that caused it. They worked in that form, then they went out to the general population. So we hope that that's the same pathway we can follow. Okay? Yes, ma'am.
I wanted to know, are there side effects to the tracer for beta-peer?
No. So the question is, are there side effects to the tracer for beta-peer that shows the the plaques in Alzheimer's disease? There are no side effects of the drug. I did mention you have to have a PET scan. That means you're going to get some radiation exposure. The radiologists have it worked out about how much radiation you're allowed to get a year and still be safe, so you don't get radiation side effects. And the PET scan is about 1/5 of the maximum safe amount, so you could potentially have 5 PET scans in a year and still be safe. But the tracer doesn't have any side effects. The PET scan would have side effects. Yes, ma'am.
I've often wondered, I've been a nurse for 40 years now, and when I first got out of school, we would have patients that were diagnosed with organic brain syndrome and senile dementia. And then it seemed like 15 years after that, it came into Alzheimer's. Were those Alzheimer's at that time, or is it something totally different?
So the question is, has the diagnosis changed and has the terminology changed? Let's put it this way. the first Alzheimer case, the first recognized Alzheimer case was reported in 1906. And it took until 1984 until we had a standard way to make the diagnosis. So 30 years we've been making the diagnosis in the same way. Before then, there were multiple terms for what I think is Alzheimer's disease dementia. Hardening of the arteries, senility, organic brain syndrome. I think they were Alzheimer's disease. Why was it take so long to become an issue and to finally try to organize and get a standard approach to this illness? Back in the 1900s, 1906, first recognized Alzheimer's patient, what was the life expectancy in the United States? Anyone want to guess? 47. People didn't live to the age where they got it. It wasn't a problem. Until the 1970s, now this is when, people started recognizing this baby boomer group is going to age, and what that means for the future, that this was a huge problem. So it's only with the aging of our society that it got people to really appreciate the magnitude of the problem. And I'm going to tell you, it's a huge problem. We spend about $215 billion a year in the United States caring for Alzheimer's patients. It's only going to grow. The first baby boomer turned 65 in 2011. And they are going to really cause a tremendous increase in the number of individuals who get Alzheimer's. 1 out of 8 persons over 65 is going to get the illness. We can't afford $215 billion now. So what are we going to do when this huge problem becomes an issue for all of us? It's going to bankrupt our healthcare system. So, sorry, I was on a soapbox there for a little bit. Sir, you had a question.
Yes. If you have one parent that was diagnosed with Alzheimer's at 80, let's say, died around 90, what is the likelihood that a particular child will...
Right. So the question is, if you had an affected parent who developed the onset of symptomatic Alzheimer's disease about age 80, lived for about 10 years, is there a genetic, an inheritable risk for that offspring? Pretty low, pretty low. When the onset of the symptomatic disease, the younger the age at which the symptomatic Alzheimer's disease begins, the greater the risk. So below age 80 is when we start to worry about a family history. Age 80 is sort of on the cusp. So some increased risk, but not very much.
What about two parents?
That's rare enough that I can't answer that. We don't know that. Okay. Sir?
Well, you had mentioned that by 75, about a third of people have it, quite towards the two-thirds don't. So my question is there any studies being done, different have got any causative factors, are there any research being done on what actually causes the disease rather than just trying to cope with it?
Right. So the question has to do, what causes Alzheimer's disease? Very, very good question. And we've pointed out that this is an age-associated illness. The older we get, the more likely we are to get it. So we'd look at the aging process. And here the brain turns out to be unique among all of our organs, all of our tissue. It's unique because we're born with virtually all the brain cells we're ever going to have. Everywhere else in the body, cells turn over. You cut yourself, you scrape yourself, your skin, it heals, grows new cells. You lose brain cells in your brain, you don't grow new cells. So that's one thing. You can't replace brain cells. Second, because they don't turn over, they have no ability to they have to have a mechanism to protect against the byproducts of brain cell metabolism. And the brain cells are among the most metabolically active cells in our body. They're always working, even when we're asleep. But the process of, it's called energy consumption or bioenergetics, spins off some toxic problems. So these brain cells have developed mechanisms to try to protect against the toxins, which we know can kill brain cells. And they do a pretty good job, but maybe over a lifetime, they wear out. And so there's something called oxidative stress, and maybe with age, that becomes more prominent. So that's one. Number two, we're finding out lots of things through an evaluation of those susceptibility genes that we talked about. One is important to find out how much risk they impart, but it's even more important to find out what those genes are supposed to do normally. And a lot of those genes have something to do with inflammation. So maybe inflammatory causes. A lot of the genes also have something to do with processing amyloid. I think amyloid's a key to this also. It may not be the only one, but it may be a key. So we have to do a better job, but these are some clues that we're working on. You had a question. About what? Yep. Yeah. Yes. Oh, sorry, I've got to repeat the question. Do they have an accurate test for testing the gene mutation? Yes. Why would someone get genetic testing? Okay. So recognition of these families comes for two reasons. One, there's a true dominant inheritance pattern. 50% of individuals in each generation over multiple generations have the disease. That's number one. Number two, remember, it's early onset, age 45. It's unusual. Okay? So that meant people looked for mutations, and the first mutation that was discovered, by the way, happens to be in the amyloid gene. Okay? As a matter of fact, all the gene mutations have something to do with amyloid. That's why I think amyloid is such a big factor. Why would someone get it now? Why would they get genetic testing now? By the way, in the DIAN study, remember what I said, they know they come from a family that has a gene. It's been documented. But they don't know whether they have it. We will allow them to be tested if they wish. We'll pay for it if they get genetic counseling. Because even though we've started a prevention study, do we have something to offer them now if they're gene positive? We don't. So it's an emotionally harrowing process. So we do the testing for research. We don't do it for diagnosis unless they ask us to do it after genetic counseling. And we do it for research, again, to find out what those genes are supposed to do normally. Then that gives us a clue, now that they're abnormal, what the process may be. Question?
Yes, I wondered about in symptomatic AD, as you described it, always gets worse. It always ends in death. And during that process, I'm aware, but only vaguely, of the PA program in San Francisco.
I'm not aware.
You don't know?
Nope. So tell me about it.
Well, it's a coping mechanism. It's a treatment that involves a regimented program for sufferers from Alzheimer's in movement and nutrition, but it's very, very regimented for them. But it seems to have these positive effects during months and years of their life.
Right. So the comment has to do with a program to help affected individuals cope with their progressive Alzheimer's disease. Here are some general concepts to think about, and ones that I tell my patients. One is stay engaged. And engaged physically, exercise, mentally, and socially. People seem not to progress as rapidly. Two, healthy diet. Now, unfortunately, they say, what's healthy diet? And I say, all the things that taste really good, don't eat. And three, what you just said, I don't know if this is apropos, but routine. Alzheimer patients do best when they follow a regimented routine. Now, it's so terrible to have Alzheimer's disease. However, in most cases, it's worse for the family. The Alzheimer patient, to some degree, is protected because they don't have insight into their problem, by and large. I have maybe 1 out of 5,000 patients with Alzheimer's disease, dementia, symptomatic Alzheimer's disease, who came to me himself. The other 4,099, the family brings it. The family knows there's a problem. I can ask an Alzheimer patient, how's your memory? Fine. You don't have any problems? Well, I'm a little more forgetful. Is it a problem for you? No, not really. So they're a little more protected. And now there are some people who do have insight, but mostly they don't. So it's the families that get devastated as much, if not more, than the patients. Was there a question in the back? Yes, sir.
Have you found in your studies that whether Aricept and Dementia provide any benefit?
So I thank you for raising the question about therapies. We have, let's see if I get that right, 4 drugs that are approved by the FDA to treat the symptoms of Alzheimer's disease. Here are the brand names: Aricept, Exelon, Razidine, and Namenda. Those are the brand names because you see them on commercials. All of them, except Namenda, are now available in generic form. So, let's see, be very careful. Everyone here who works for a pharmaceutical firm, raise your hand, please. So if you test lots of people with Alzheimer's disease dementia, symptomatic Alzheimer's disease, and you give half of them Aricept and half of them a sugar pill, the people with Aricept, you test them on that mini-mental state, every time you test them, they will do better than the people on placebo by about 1 mini-mental state point. So yes, they benefit, but they benefit to a very small degree. So I think the way I like to say it is modest benefit, and then the next thing I would say is we need truly effective therapies. There was a question way back, sir.
Over the past 4 years, 5 years maybe, there's been a lot of journal articles linking diabetes, type 2, with Alzheimer's, not only disease.
So the question has to do with diabetes and linked to Alzheimer's disease. So a couple interesting aspects. We talked about engaged lifestyle and healthy diet. We think that people who in midlife have cardiovascular problems, hypertension, cholesterol, diabetes, obesity, are more likely in late life to have dementia. And it turns out, specifically with diabetes, is the brain has lots of receptors for insulin. And it has those insulin receptors, particularly in those brain regions I said are devastated at the time the symptoms first begin. So vulnerable areas of the brain. So one idea is there's a lack, maybe not of glucose, but a lack of insulin stimulation or providing some positive benefit to the brain cells in these regions. And people have thought about for a long time how we might test out giving insulin to Alzheimer patients. Well, we can't give insulin in the standard way, right? Because most Alzheimer patients have normal blood sugar levels, and if we give them insulin, we're going to drop their blood sugar levels. Except now they've developed a way to give it through the nose. If you put it in the nose, it gets up into these nasal passages, and there's a very thin part of the skull that separates the nasal passages from the brain. So the insulin can actually get into the brain through the nasal cavities. And so we've just started a trial of intranasal insulin. Let me see if I can remember it. Study, S of nasal, N, insulin, I, to fight, F, forgetfulness, sniff. That's the name of the study, sniff study. And so it's just begun. We're a site at Washington University. We're participating in that. There was one, yes, ma'am? Yep. So I saw a patient today who I first diagnosed in 2001. So there's someone who's at least 13 years. The longest I've seen is 22 years. So it's not hard and fast. And I think a lot of it has to do, well, some of it has to do with, the general health of the person, how healthy they are. They don't succumb to other things. So it's not hard and fast. I'd say it another way, and I don't mean to be trivial, but, I think every Alzheimer patient is unique. They have general characteristics that they share with other patients, but the way they progress with the illness is unique to them. Yes?
So there's been some recent evidence that suggests that neurodegeneration can be triggered by activation of chemical elements. Is there any link there with Alzheimer's?
I'm unaware that there are. I don't know that. I'm sorry. Yes? So the question has to do, proper lifestyle, staying engaged, healthy diet. No one's asked me yet about red wine, but and if you do it for a long time, beginning early, is that even more protective? So the answer is I don't know. I'm sorry, I don't know. But there's a caveat to all of this, and that is, we look at people who have been diagnosed with Alzheimer's dementia, and we look at similarly aged people who are cognitively normal, and we find out that as a group, the cognitively normal people are more likely to have engaged in healthy activities. Now, does that mean it's those engagement activities that protect them against getting Alzheimer's disease? Well, maybe not. So say the people who like to play chess or do Sudoku or play bridge, mental activities, luminosity. Maybe they had a bigger brain to begin with. And that's why they play chess. It's not the chess that protects them. You see? And there is no proof that doing these things that I tell my patients to do will protect against Alzheimer's. And I almost hesitate to be too strong with this, because I have had a couple of patients, families tell me, he did everything that the books say to do, and he still got it. And Nobel Prize winners get Alzheimer's. So these are in no way proof that we can prevent Alzheimer's. It doesn't hurt to do it, but there's no proof that it's going to benefit us. I'll take one more question. Sir? I'll take two more questions. Did you have your hand? Yeah, two more.
In one of your slides referring to the DIAN project, there was a line that indicated drug treatment period equal 2 years. Why just 2 years?
Okay, so the question has to do with the study design of the DIAN study, and I skipped over it, so I apologize. We are testing two different antibodies, and we're going to test them over 2 years to see which one has the biggest effect in reducing the brain amyloid. We're going to choose that drug for another 3 years to see if it can stabilize cognitive ability. So it's really a two-part study. The first 2-year study is simply seeing which one engages the target the best. And then we'll choose that for a treatment study. Last question. Well, so there are a couple of things. Yeah, so I think, yes. Shall we bring up the red wine? I think healthy lifestyles and healthy diet are apropos. If there is a family history, your aunts, uncles, grandparents, who also have early onset dementia, then I think it's worthwhile exploring that pedigree to see if there could be indication for some testing to see if there's a genetic factor playing a role. And I will tell you that in addition to that, even if there isn't, we are doing many studies at the Alzheimer's Disease Research Center. One of them is something called an adult children study, where you have an affected parent with onset before age 80, as I mentioned, and we're going to compare the biomarker changes and the cognitive changes over time. Unfortunately, you have to be 45 to enter the adult children study, but so listen, I'm very impressed with all of the questions, and I'm sorry I can't address many of them, but I do appreciate you coming out on a rainy night. Thank you very much.